access it if they want. And what Tarek's asked me to talk about is a little bit on how to find articles for Journal Club, what's good, what to take notice of, talk about this paper in particular, and talk a little bit about the stats that we used in this paper, and go through some critical appraisal, and then have some time for a little bit of discussion and questions, and Tarek's got something he wants to share as well. So how to papers. So I think lots of the time we feel like the guy on the left there, and this is all the papers we've got, overwhelmed. Oh, someone's saying there's no voice. Tarek, can you hear me?
I can hear you very good.
Okay. So it might be a problem with someone's speaker their end. I'm going to carry on then. They can talk in the chat, I guess. Tarek can hear me.
Yes, I can hear you.
Problem your end. Okay, I will let you resolve that. So we're feeling overwhelmed. So where to go? So EB Neo is a great source of papers. They have social media, they have an email newsletter. They'll send you the latest neonatal papers every month. They're really good. The other one is the Incubator Journal Club. For all of us who have got a commute, it's a good way to get a quick update on a wide range of papers from the neonatal team with the Incubator. And they have a range of other podcasts, but the Journal Club's really invaluable. I've set up a Google Scholar alert as well, so you have a Google account, and then you can get it to send you through email any papers that have come out, particular author or particular subjects, or related to your own research if you've published anything. And you can do the same with PubMed or Ovid Medline. And then you can also look for the high impact relevant journals. So Archives of Disease in Childhood, Fetal and Neonatal, which everyone in the UK gets as part of their membership at RCPCH. And I think if you're a broad membership as well, but you could look for Pediatrics, JAMA Pediatrics, high impact journals. So then you need to think, well, what's good and what goes in the bin? So looking through EB Neo, looking through things that the Incubator raised can give you some idea. But when you're looking at this, you might want to think, so I'm going to bring something to a journal club to share with my peers. Who's your audience? Are you in a high income country? Are you in a low or middle income country? That might depend whether the paper's more relevant to you. Are you in a surgical NICU, or maybe you're looking for a more generalist pediatric audience? What's the aim of your journal club? Are you wanting to answer a clinical question from your unit? Have you had a particular challenging baby and you want to raise perhaps how you could have done something different? Maybe you want to bring some brand new practice changing research, think how we're going to do something different in our unit. Maybe you want to practice critical appraisal. So you want a paper that's actually, it's not such a good paper, but you're going to practice together, picking some holes in it, critiquing it. Or maybe you want to go back to the classics. Maybe you want to look at some of the classic big neonatal trials of the past 10, 20 years that have really changed practice. And you want to share with your peers and colleagues, some of these big papers that really made a difference. And that'll affect whether you want to choose that paper. Where is the article published? Is it in a reputable journal, like one of the ones we mentioned, one of the JAMAs, one of the BMJ stables? Is it in New England Journal of Medicine even? Or is it a paper that perhaps is in a journal that is more like you pay to access, and perhaps the journal is not reviewing papers so well? Is it PubMed ID'd? And also, can your audience access the full paper? I think that's particularly important for where you've got a clinical audience and they might not be able to get access to all of the journals and they don't want to pay money for that. What country do the authors come from? Where did the study take place? And again, that ties into whether you think the paper will be relevant for your audience necessarily. And what study design is it? So you might want to pass on case series because ultimately it's not going to be very high up there, the pyramid of evidence, and not make as much difference. And when did it take place? And when was it published? Again, depends. Are you going to look at the classics and you're happy to look at something from the early 2000s? Or do you want something that is really relevant to your patients right here, right now? And these can all sort of filter out your papers, even before you do a full critical appraisal. So we're going to come to this paper, which is open access. It's new. It's in Journal of Pediatrics, so acceptable journal, and from Sweden. But hopefully this is relevant to all of us who look after extremely low birth weight infants. So when we start looking at a paper, the best way to summarize it is PICO. This is population, intervention or exposure, comparison, and outcome. And I'll go through all of these one at a time. So, what was the population of this paper? So, this is a Swedish national cohort, which was born from 1990 to 1992. So it is a little bit of an older cohort, but the advantage is these participants were 26 to 29 years at the time of the study, because this paper is all about the self-reported quality of life in adulthood in this national cohort of Swedish infants with extremely low birth weight. So their exposure was equal to 1,000 grams extremely low birth weight, ELBW. And the comparison was matched controls born appropriate weight for gestational age at term. And the outcome is the health-related quality of life measured through questionnaires, plus looking at the health conditions and diagnoses, looking at both physical and mental health conditions. So that's our PICO. So that summarizes the paper in a short form. And sometimes we put an S on the end of PICO to make it PICOS. What was the study design? So this is a retrospective cohort study. So a cohort study follows a group of individuals from the point of exposure forward to the outcome. But if you do it retrospectively, you can then look at the exposure in the past and look at that outcome in the past as well. And that's quite a common thing for studies to do. And it's interesting to note as well that this study, if you have a look at it, has extensive patient and public involvement. And this led to the redesign of the study. And actually, they put a big table explaining exactly how families and parents contributed to the design and input into this study. So that was really nice to see, and it's something that we'll probably see more as studies go forward, particularly as national funders like to see that families are involved in sort of how we do research. So the background, extremely low birth weight children are known to have increased rates of physical health conditions, so cerebral palsy, epilepsy, asthma, neurodevelopmental conditions such as autism or ADHD, and higher rates of visual impairment, hearing impairment, and learning difficulties or learning disabilities. And that's been well established. It depends on the gestation and the morbidities that the babies experience in the neonatal unit. There's also some previous evidence that suggests that very preterm born adults are at increased risk of respiratory disease in adulthood, cardiovascular disease, and renal pathology with long-term renal impairment. There's also evidence that very preterm born children, particularly those extremely preterm, have decreased education and employment achievements later in life compared with term born adults, and they tend to marry and have children less often than their term born peers. So this study aimed to compare the health-related quality of life of extremely low birth weight adults compared with born at term. And that's their research question. So I think that's really relevant to all of our practice. And that's why it interested me, this paper. So we're going to talk about the methodology. So if we go through the methodology following the PICO. So our exposure group was the Swedish population register. So this is a really impressive study and shows the depth data that in Sweden. This study included all of the 633 live-born Swedish babies born from April 1990 to March 92, less than 1,000 grams, of whom 370, which is 57%, survived the first year of life. This being some time ago. They then had a really good 98% follow-up at 3 years, and they had a disability classification from 0 to 4, with 4 being severe. We'll come on to that later. They then were managed to approach 345 ELBW adults, now 26 to 29 years, and they got additional data from the Swedish Medical Birth Register, and they were able to get the parental education retrieved from the total population register. So able to link together all these different pieces of information to get the exposure group. The control group was the Swedish Medical Birth Register. It was used to select participants born at term who were a normal birth rate, so within 2 standard deviations. So if you think about that bell curve towards the middle of the bell curve, and also these adults, when they're babies, their APGARs were greater than 7 at 5 minutes. Again, they were able to get all of this information from the national registers of data, and they were able to match the adults on their municipality, so the area in Sweden, their sex, their birth month and year, with the aim of making them really comparable, because they matched up to 5 controls per ELBW participant was their aim. So they had a matched control group. So what was the outcome? So the health-related quality of life was this outcome. And this is a standard questionnaire with 36 items, and there's a Swedish version, so they were able to use that. And it includes physical aspects, so pain, functionality, how they're able to do their activities of daily living, and then their mental health, so social and emotional functioning, different components. This tends to be standardized in what's called a T-score. So this is a score where they take the outcome of this questionnaire and standardize it so that the mean is 50, so that the normal score that you'd expect is 50, and the standard deviation is also standardized to 10. So imagine, again, that bell curve is standardized around so that the peak of the bell curve is at 50 and standard deviations are 10 either side. And higher is better quality of life. The other thing is to say that previous studies have demonstrated that a difference of 2 is significant on this score for physical component, and a difference of 3 for mental component is significant. So we'll just think about that when we come to looking at the results of the study in the 2 groups, what the differences were. And as I said, they were able to actually get diagnoses for these participants, which were the International Classification of Disease 9 or 10 codes. They were able to get them from the register, and they also reviewed them with a psychologist and physician on the research team and categorized them. So they had more data on how these adults were living with different long-term conditions. So I got off the internet. So this is just an idea, and this is the English version of this SF36 questionnaire. So in general, would you say health is excellent, very good, good, fair, poor? How is it compared with a year? How are you affected with vigorous activities like running, lifting heavy objects, sports, doing groceries, going upstairs? So you can get an idea that it gives a thorough idea of all of the different aspects of life. It also has this sort of dimension to it. So here we've got, have you had emotional health problems that have mean you spent less time at work or activities? Whether you struggle with social activities, your pain, all of these different aspects. So I think that's a reliable outcome that they've used. I just want to show this briefly. So this is included in the study, and this shows just how much they were trying to chase up their participants to get them included. So they had an invitation letter, they called them, they texted, they kept on calling, they did reminder letters, and all through they were doing their assessments at the same time. So after all that chasing up of everyone, how did they do? So they got 201 out of the 345 ELBW adults consented to participate and have the survey. And of the control group, they got 327 of the 1,259. So only 26% of the control group adults consented. And they also mentioned, just out of interest, and I thought this was quite interesting given the sort of what we're talking about with disabilities and challenges with life, 24 ELBW participants, which was 11.9%, and 10 of the control participants had help with doing the questionnaires. So if they had difficulty with reading or having the questions explained or inputting the online questionnaire. So that shows that already you can see there was more of the ELBW participants had difficulties. That was an interesting aside. So often we have this figure 1 flowchart where you see the study flowchart, how many patients dropped out. So you had started with the ELBW infants, we had a number that died, the children were alive, were then followed up in the Swedish healthcare system and assigned their disability level. There's a few further children did die, and then you have 345 eligible adults. I believe this is a typo here because they've replicated the figure from earlier, but you can see that 58% participated in the follow-up and 49% completed the survey. So overall, a half were successfully followed up. So what's quite good is that they then talk about of the participants that were followed up and participants that dropped out, they were able to compare them. So this is quite useful. So here we have in the first column the respondents, and then you have the non-respondents, and then you have the control respondents. So these controls are the term-born, and then the first two columns are the ELBW. So we can see that, for example, if we look at the birth weight, the respondents, the mean was 850 grams, the non-response was 837 grams, and the controls was 3,567 grams, which makes sense because the controls are the term-born, appropriate sized babies. So the controls are different, the respondents and non-respondents are broadly similar. But let's look at the second bit of information they give you. So here we're going to compare again the respondents and the non-respondents. We want to look at things like the disability. So we talked about this disability level from 0 to 4, with 4 being the highest level of disability. And you can see that, for example, in category 3, there was 8.6% of the non-respondents had category 3 disability versus 3.5% of the respondents. So non-respondents had a higher rate of disability. We might want to think about why that might be. We also had lots of information through this data linkage about the years of education from both mother and father. Again, really impressive amount of data that the Nordic countries have. But again, you can see that the non-respondents had their mothers tended to have a lower level of education, and they tended to have more mothers of a non-Nordic country of birth, although this was not statistically significant, they said, but the education was. And again, we might want to think about why that might be, that populations with a lower level of education in their families and more likely to be migrant are less likely to participate in this study. So there's already some things to think about in terms of the critical appraisal coming up from this. So I just want to touch on this. They mind all the other data, and you can see it's divided into physical health, mental health, psychiatric disorders, developmental disorders. And again, you can compare the controls, which is over here with this blue box as the percentage, and then the respondents and the non-respondents in these red boxes that I put up. And you can see again, broadly, the ELBW participants have higher rate of, say, cerebral palsy, 6.5, 14 versus 0.6. There's much higher rate of physical disabilities. You can see differences in the intellectual developmental disorder, and you can even see differences in the mood disorders. But also what's worth saying is you can see that intellectual developmental disorder is much more common in the non-respondents. Again, fitting with this, non-respondents have a higher rate of disability than those who actually took part in the study and answered the questionnaire. Okay. So here we come to the key result in table 4 that is really going to answer the research question of this study. So we're going to compare the health-related quality of life between ELBW, who did answer the question, so 168, versus the matched controls that they selected. So we can see across physical functioning, bodily pain, general health, vitality, social functioning, emotional, mental health. And here at the bottom, you've got the physical component summary and the mental component summary. So with the final ones here, you can see if we compare the mean of the controls and the ELBW, physical is 55.7 with the controls at 56.4, and mental component is 45.3 versus 46.7. It then shows the differences and the 95% confidence interval. So let's remember that these scores were scaled so that 50 is the average you'd expect, and the standard deviation is 10 around that. And we said that there's differences of 3 and 2 were significant. So the 95% confidence interval, which is the last column that says upper and lower, you can see, so for physical, we're 95% sure that difference between the two is between less than minus 0.5 to plus 2.0, with controls having higher. And then for mental component, the 95% confidence interval is minus 0.9 to 3.7. We're 95% sure it lies somewhere in that. But interestingly, that does touch on significant differences between them, with controls being higher. That is within the range of possibility. But overall, there's not a statistically significant difference found in these means between the two, although the certainty does overlap with there being some differences. We're not quite sure. So no statistically significant differences were found in health-related quality of life across physical and mental components. Just a note, how did they test these? They did a t-test. So this is to test a numerical variable between two groups which so we can definitely say it is a normal distribution. I want to just touch a little bit on the regressions that they also go through, and talk a little bit about their stats. So they performed simple, what they call simple linear regressions, or single variable linear regressions between the different data they've got and the physical component score here. So you've got the ELBW and the controls. They've done them across both of them. So for example, we could say that they've picked up that small for gestational age has a, see what this has, B in the B column. That means beta. So this is the gradient of the slope, and I'll get onto this in some slides talking about. And it says minus 2.2, and the p-value is less than 0.05, so they've declared that to be significant. That means the presence of small for gestational age meant that on average, the physical score was 2.2 points lower, and that was statistically significant. And the idea of doing all of this is they then want to do a multivariable linear regression. Again, we'll talk about that. So they just looked at everything and trying to see, is there anything there that might be statistically significant? It must be said, if you do this many statistical tests, you are more likely to find not sure what happened there.
Yes.
Okay. Sorry,
Yeah,
gremlins in the
okay, Tim?
system. Yeah, it gremlins somewhere. Anyway, so yeah, if you just the way that p-values work is that the threshold we use 0.05 equates to a 1 in 20 chance that what you've observed essentially arose by chance, or that it arose despite the null hypothesis that there'd be no difference being true. So what this means, if you do 20 statistical tests on average, you'll probably find something with a p-value less than 0.05. So when you do this many tests, you can often find associations. So we look at the mental component as well, and they again just look through everything. And then they want to then try and use this information to build a multivariable model. And they do that. So if we look at the multivariable model, they choose the physical component summary. They then just choose these ones to control. So gestational age, cerebral palsy, attention, mood, anxiety. And then they note that, again, this beta, so let's take gestational age in weeks. For every 1 increase in gestational age in weeks, the beta is 0.06. So the physical health score goes down by 0.06, which is an unusual finding. And I did double check throughout the paper whether they inverted the gestational age. I couldn't find that. So it seemed to be that higher gestational age had slightly lower physical score. But you can see here we go for cerebral palsy. This is a lot more plausible. You can see that the presence of cerebral palsy reduces the physical score by 5.3, and that's significant. And that's significant p-value. So, and this makes sense because the presence of cerebral palsy will impair your daily functioning. So, you know, going up and down stairs, doing washing up, all of those things, more likely to be difficult if you've got some cerebral palsy of some form. Okay, and then they wanted to do that again with the mental health scores as well within this extremely low birth cohort. And here, again, they demonstrate that having anxiety disorder, after controlling for the other things listed here, if you have anxiety disorder, you're on average will have a mental health component score which is 7.4 less, and that's statistically significant. And again, that makes sense because the presence of anxiety disorder will cause you to have emotional symptoms that will show up on the score. So stats pause with some graphs here, most complicated graphs. So I talked quite a lot about these multivariable regression analyses and linear regression. So let's have a think about that and what that means. So when we talk about this, we tend to go from correlation to linear regression. And correlation is really looking at a scatter graph of two things and working out, do they go with each other? So it might be, say, height and weight. So as your height increases, does your weight increase? If we take a sample of 100 people just taken off the street and we do their heights and weights, let's see. And then you can get different patterns. So let's say the middle one, it says no correlation, R equals 0. And R is the score that we give. So it's just randomly scattered about. You can't really draw a line between them. Or we could say that R equals 1 on the left in blue is a perfect positive correlation. So we find that height and weight line up perfectly. Or we might find there's a perfect negative correlation. So that wouldn't apply so much for our height and weight, but there could be things where as one variable is on average higher, the other is lower. So this R gives us an idea of the pattern. Is it highly correlated, positively correlated, or negatively correlated? What it can't tell you is, it can't quantify it. It doesn't tell you how many, on average, how many more kilos is someone for every centimetre in height they are taller. So to go from correlation, we need linear regression. So again, going back to sort of medical school examples, more in adults, we think about something like age versus blood pressure. So we think about age versus blood pressure. It's probably a highly positive correlation. As we get older, our arteries get stiffer and our blood pressure goes up. So let's say it has 0.08. Age and blood pressure go up together. Can we quantify it? Can we draw a line of best fit with the least squares difference and try and get all the dots close to the line with the smallest amount of squares? If we imagine doing it on graph paper, the smallest amount of squares between our dots and the line. And if we drew that line, could we then make predictions, one versus the other? not just looking at the shape of the smear of dots, but looking at quantifying it. I can see that Jubara has an interesting point, and I will get to that. So we present this as the gradient of the line, again going back to school, y equals mx plus c, all of those bits. So basically, for every 1 year increase in age, we could say systolic blood pressure on average goes up by 2 millimeters of mercury if we were quantifying it. So that's quite powerful, and just more powerful than just saying two things are correlated. Now we can describe it as a pattern. So what about multivariable linear regression, which is what they did? So let's do age versus blood pressure again. What about weight? Maybe if you're heavier, maybe if you're obese, then your blood pressure is going to be higher. So that could be a confounding factor, because that could be associated with both the exposure of age. As we get older, we get heavier, and also the outcome of blood pressure. As you get heavier, the blood pressure is higher. So we need to adjust for that if we want to know about the relationship between age and blood pressure. We need to adjust for the weight. All we need to do is add another dimension. So if you were trying to do this manually, with the last example, you could think about that as a straight line and trying to make the dots close as possible. But now we've made a 3D graph, and really this can only be done by a computer easily. But you can see how you could adjust for this in 3 dimensions by adding a slope in 1 dimension and a slope in another dimension to make a 3D shape. And then we might find for every 1 year increase in age, systolic blood pressure increased by 1.5 millimeters of mercury, controlling for weight. You could then look at it the other way as well. You could say for every extra 1 kilo of weight, systolic blood pressure may increase by 1 millimeter of mercury after adjusting for age. And you can look at these relationships controlling for each other. You have to select them carefully. So what I will do is I will just go back. We had a question about the wider traditional neonatal morbidities. BPD and IVH show weak or non-significant associations with adult physical health score. So so we look at the ELBW group here. They did find that, for example, having IVH over grade 3, yeah, it is interesting that they didn't find, they found that the presence of IVH grade 3 had a negative effect on the score, but it was 1.5 and the p-value was not significant. Similarly, they found ROP had a positive impact. You could see PDA. What I would say would be interesting to look at here, I think it's a really good point. I mean, you know, we could see that for neck, the beta is positive, so you can see it was a positive reaction, a positive association. This may be because of selection effect, because you have to remember that if we have significant neonatal morbidity, these are children who survived, so they're maybe better off. The children who had neck and didn't survive won't be in this study. So I wonder whether there's an aspect of competing risks, competing outcomes here that we don't see the children who didn't survive. You were just selecting to the healthier ones. Tarek, sorry.
Yeah, Tim, it may be related also to the non-responders, because the non-responders with significant morbidity didn't respond, and it is a huge number, maybe also.
Yeah, no, I completely agree. And yeah, we're going to get onto the talking about the critical appraisal. The risk of bias from having these non-responders is also high. And again, it can mean that you get slightly unusual groups and you can get slightly unusual relationships because you're not including all of the children. And we did identify that the more disabled babies, well, the more disabled adults who were probably babies who had more significant neonatal morbidity, they're not included as well. So we have to wonder slightly about some of these associations. particularly like with a relatively small number of children with a poor follow-up. But yeah, really interesting point. So that means we're getting on to thinking about the critical appraisal. But the conclusion of this paper. So overall, the authors say that adults who are born extremely low birth weight have a higher rate of physical and mental neurodevelopmental conditions than term-born adult peers. However, the physical and mental health related quality of life of these ELBW adults is similar to term-born adults. Or after adjustment, increasing gestational age and presence of cerebral palsy was associated with lower physical health-related quality of life. Autism and anxiety was associated with lower mental health quality of life as well. But their main conclusion is that ELBW adults have similar quality of life. So think about the critical appraisal. Yeah, psychosocial variables. I think what we'll do, I'll come back to that. Let's talk about the critical appraisal and we can open up the floor a little bit more. So I'm just going to use the CASP framework. There's a range of different critical appraisal, but I think the CASP is quite nice because it's free. There's a CASP tool available for every type of study. If you just put into Google CASP, it has all the study types you could want. And it's quite suited to a journal club for a generalist or clinical audience. So I'll go through some of the questions. So section A of CASP is the results valid? Did the study address clearly focused issue? I think yes, there was a clear PICO. Was the cohort recruited in an acceptable way? And yes, they did really try. They got a whole population registry that was national across Sweden. That was good. Was the exposure, extremely low birth weight, accurately measured to minimize bias? And I think we can say yes. We have good, we know that their records are good for birth weights. We know that birth weights are they're measured with a high degree of accuracy in high income countries. Was the outcome accurately measured to minimize bias? So we know that the questionnaire is a reliable one from previous studies. There's potentially risk of bias. Is there a degree of objectivity because participants know their exposure, they know whether they're born preterm or not? How does that affect how they view their life and their experiences of having pain and emotional things? I suppose ultimately you have to trust how people respond to the questionnaires themselves and their own feelings on their own life. So I guess it is inherently subjective. Have they taken out confounding factors? They did attempt to control for different aspects in their multivariable analysis, but as we discussed, there may be some problems with how they went about that. Was the follow-up of subjects complete enough? So although they had a really good follow-up up to 3 years with their medical assessments in the Swedish health system, only 49% completed the health-related quality of life survey. And the dropouts tended to be more disabled. They tended to be have differences in their socioeconomic status, their migrant status. And so there's a risk of bias that you're only selecting for the adults who had a higher quality of life, because those who are more disabled weren't able or didn't want to answer the survey. And was it long enough? I suppose you could say 26 to 29. For those who completed all of the follow-up, that is long enough. It would be really interesting to see this continue into middle age and get an idea of the longer term, even longer term outcomes for our preterm babies.
I appreciate you answering the phone. Would you ask Yvonne when she does?
And so section B is what the results and how precise the results. We did talk about this, but just to remind us, this is the main table of our results, and it asks about how precise. It's good that they give us both the mean, the standard deviation, and they give us the p-value and the 95% confidence interval. So that's a really good way of presenting the statistics to give you an idea of the range of outcomes that are possible. No significant. And so do you believe them? So extremely low birth weight adults potentially may have similar health-related quality of life. I'm less certain about their multivariable analyses. It depends on how much you worry about the biases introduced. Will the results help locally? I guess perhaps it might help with your counselling, that extremely low birth weight adults can have similar quality of life to term-born peers. Not sure whether they all do, but it does show that they can do. And can results apply to the local population? So, I'm working in Leicester. It's a relatively diverse but relatively deprived city in the United Kingdom. Sweden is a similar high-income country to the UK, but maybe they have a greater social security, perhaps compared with us. And perhaps the current population of babies in Leicester is more diverse than the study population, where they had 7 to 17% of non-Nordic babies in Sweden in the early 1990s. Certainly our population of babies in Leicester, which is about an ethnic minority majority city, is going to be way more diverse than that. So perhaps it's not quite able to be applied. Does it fit with other studies? So there's been a range of small studies, a range of qualitative studies that suggest that disabled people have report similar quality of life to people without disabilities, and also that neonatologists are relatively more negative about the future quality of life of our babies than families report. So this probably does fit with other evidence that, say, extremely low birth weight adults can have similar quality of life to term-born peers. And what are the implications? I guess implications for counselling and discussion and, answering questions from families. So thank you for listening. Questions and discussions welcome. I'm going to stop sharing for now. I think we had a question from,
Yes, thank you,
there's
Tim.
questions in the chat.
Discuss Dr. Jubara does the inclusion of psychological variables like example social support improve prediction of BCS score in extreme low birth weight infant. So I have something interesting here on the confounding factors. If you allow me to share my screen, then it will be helpful answering Dr. Jubara question. And also some of the, you can see my screen now. You can see my screen now?
Mm-hmm. Yep.
Yeah. So this regards question of Dr. Jubara, the confounding variable analysis, they assessing controlled and unmeasured factors that may influence health related health issues, quality of life outcomes. They mention here adequately controlled confounders like parental education and country of birth. And this study done in Sweden, and we know how the quality of life there and how the healthcare system there. And also they find the biological sex and multiple birth status, gestational age and birth weight parameters, and the potential unmeasured confounders that family support system and healthcare access, current socioeconomic status like versus birth, SES, psychological resilience and coping mechanism. And I think Tim mentioned it on the study, and he said the high quality of life, some of the people who didn't respond, who has less education, and also some of them was like me, most of them was immigrant, as I understand. So is this can answer Dr. Ajbara question, Tim?
Yeah, I think the psychosocial variables are very important social support, and we didn't have all of those, like you say, the unmeasured confounders. I think when you're looking at the maternal education, there's another study that's just in archives recently from the Netherlands, looked at children who born very preterm and special educational needs, And actually, they then did an analysis where they looked at low maternal education, and it makes a huge difference, and it does predict a lot. So we have the environment in the home and the parents' education, and then the society around them, all are really important in the outcomes for our babies, which means it's not just what we do in the neonatal unit, it's actually what happens after they go home as well, in the wider society.
Thank you, Tim. And you mentioned also when choosing what is good one, you mentioned about what is your aim of like journal club. And our aim today is very clear. We need to learn about statistics. And you mentioned good thing about like linear regression and also t-test. Also, in this study, they mention about what's called interaction analysis or sensitivity analysis. Does it mean?
Okay, so sensitivity analysis is the easier one to talk about. It just means an analysis where you might change something and repeat it. So maybe that you looked at gestational age as a continuous variable in one go, and then you said, oh, but what happens? Is it different if you group it into different categories of weeks? And then you say, I'll do a sensitivity analysis. I'll repeat all my analysis and see if the models are different with having them as categories instead of continuous. So sensitivity analysis can be anything that authors want to do to just say, if I tweak one bit, do my results still hold? Interaction is a little bit more tricky to understand. So an interaction is where the presence of one factor affects whether there's a relationship with another factor. So an example would be whether giving ferrous fumarate increases your hemoglobin level. And the interaction term would be the presence of iron deficiency anemia. So if you have iron deficiency anemia, there is a relationship between taking ferrous fumarate and increasing your HB. If you don't have iron deficiency anemia, that relationship is absent. You can take all the iron you want and your HB won't go up because you're not anemic, you're not lacking in iron. So the interaction term there would be between iron deficiency anemia and ferrous fumarate increasing your HB. It can be a little more tricky in neonates. Sometimes they look for interactions with sex because we know that boys tend to do worse than girls in neonates, or interactions with gestation or things like that. But yeah, the iron deficiency one is the easiest one to understand. And I believe Tarek's got something to share as well, Tarek.
Yeah, okay, so I will please prepare your questions about what you heard from Tim. And while you are preparing your questions, I want to share this again. We are talking about premature infants. If you remember the last webinar with Professor Colin Kraft about the follow-up of premature babies. And here she shared one of the articles that discuss this in clear. This article, I will share it now and I will go back to what I did. It is from the American Academy of Pediatrics, and it's a primary care framework to monitor preterm infant for neurodevelopmental outcome in early childhood. This is very important, as Tim mentioned, even from the previous study that he showed that it is very important in counseling. So what happened, what I did, I took this graph and I put it here, and I make a risk assessment depending on this graph. And you can see here, this is the article, and surprisingly, you'll see any baby less than 28 weeks, as we know, they are extremely birth weight and also low gestational age. So first, you know the color, like if the color is red, the risk is more than 10%. Yellow is 1 to 10%. Blue is less than 1%. Gray is baseline. So I will start from the extremes. Like if I said, is the gestational age less than 28 weeks? If I said yes, it gave you all in high risk, and we agreed that high risk is more than 10% for cerebral palsy, visual impairment, intellectual disability, and hearing impairment. So this is very important. We know that on daily practice, we saw that preterm less than 28 weeks. And when you talk to the parents, um, also keep in mind that in the future, they may have, I know it is, chance is more than 10%, and this is really, really too big. Just be careful while talking if they ask you about the prognosis, about the outcome, because being preterm less than 28 weeks alone is a risk factor. If I did a new assessment, if I said, no, he's not less than 28 weeks, they ask me, is there is hypoxic ischemic encephalopathy or periventricular leukomalacia? Okay, imagine I said yes, it will make more, but I said no. Is there is surgical retinopathy or prematurity or moderate BBD? I said no. Is there is necrotizing enterocolitis or grade 3 to 4 IVH? I said no. Is there is mild BBD or grade 1 to 2 IVH? I said no. Is the gestational age 28 to 31 weeks? No. 32 to 36 weeks? No. More than 37, and this is extreme no. So he said standard follow-up. No need, no added, no risk here for more than 37 weeks. So we'll go back. If I said no, but I said there is evidence of BVL, and we saw BVL. We have currently in our unit one was very severe BVL, and really, if I said yes here, what will come? So these babies with BVL has the risk of cerebral palsy and visual impairment, even hearing impairment, and also moderate risk of intellectual disability. And this also important in discussion. Again here, no. Then if there is surgical ROP or moderate BBD, yes, here again, risk of cerebral palsy and the risk of hearing impairment is high. Visual impairment and intellectual disability, the risk is moderate. So if we continue with this, it will be good. So I want also share something here. Now, about Tim mentioned some clinical implication about counseling. So the implications not only for neonates and not only for pediatric people, adult or for patient and families also. So for neonates, we said counseling families, most extreme low birth weight, which they are less than 1 kilo, report acceptable quality of life. So some of them, we know, as the study said, there's acceptable quality of life, but higher morbidity burden is real. Focus on preventing cerebral palsy, supporting and mental health. This is for the neonatology. For the pediatrics, definitely you see some of these babies on the clinic or for admission on the pediatric ward. They should have a screen for autistic spectrum disorder and attention deficit hyperactivity disorder and anxiety, because this study mentioned a lot of babies had in risk of having ASD or ADHD. So early intervention is crucial, and transition planning to adult service. For adult, any adult who was extremely birth weight need really lifelong monitoring. Mental health, particularly vulnerable, and cumulative comorbidity has amplified effect. For patient and families, resilience is possible despite challenges. Self perception may differ from object health. So this is my input here. I hope some now have some questions. Again, yes, Jubara, thank you for your sharing with us. Jubara, I will introduce Dr. Jubara Alala for you. Dr. Jubara was my mentor on NRP in Saudi Arabia, and she's a consultant in National Guard Hospital in Jeddah, and she was really famous in the Middle East and sharing a lot of her experience regarding NRB and other topics in many conferences all over the Gulf areas. So Jubara asked here another question. You can read and answer, Tim.
Yeah, so it's another really good question. So how does predictive value of these factors change when using multivariable models instead of simple regressions in this paper? So I just answered in text, but basically the single variable linear regression just allows us to understand the association between one factor and another. But this may be subject to confounding. So, for example, if you're looking at the relationship, say in another study, between severe IVH and quality of life, or IQ measured later, there would be confounding with gestational age, for example, because extreme preterm babies tend to get more of the severe IVHs. So it would tell you that having IVH may be negatively associated with IQ later on. But the multivariable analysis may be what you want to do if you want to pick out how we control for other things. So how does IVH grade 3 affect your IQ later on after you adjust for gestation? I think Dr. Jubara has got a flight to landing. So thank you very much for the question. And I just explained that if you have multivariable analysis, that does mean you can then develop the tools. The studies can then make models, and they can go into the tools like Tarek was doing. So you can adjust for different things, the presence of different factors, and you can build little models and prediction tools from that. So it does give you more complex analyses you can do. But like we discussed, it is all subject to the problem is if there's a problem with the bias in the data, then that can feed through and cause problems in your models later on. So you still have to be careful. Statistics can't just solve everything.
One more question, Tim. If critically appraising a cohort study, if it is prospective or retrospective, does it make difference? Or like when we doing the study checklist, it's different or the same? Because both under cohort study.
Yeah. So in theory, it shouldn't make a difference if it's a retrospective cohort study or whether it's prospective. It all depends on how good the data is that they're able to get. So you could have a prospective data study where you made a cohort, say we made a cohort this year and we started gathering patients, and then in 10 years we follow them up and publish. If we still had a dropout rate that was high and we still didn't get the data we needed, then that could be a problem. Or it could be we do retrospective data, we look back and then maybe we found that the medical records, we couldn't actually get all the data we needed, and those additional variables that were never collected. You can't go back in time to collect them. So that's the limitation. So it's really about what the data is that you can get out of it. Hopefully, as we get more and more electronic records and good data, then the retrospective cohorts become more powerful.
Okay, so just a reminder, when we critically appraise a cohort study, we need to check the study design appropriate for the search question, prospective or retrospective, clear definition of the exposure and outcome, and selection of participant, and also assessment of the exposure. Is it accurate or measured before outcome, or blind appropriate, or assessment of outcome like valid and reliable measures, blinded or measure assessment, or complete follow-up. This is one of the things that you consider on assessing a cohort study. At the end, I really appreciate your presence, Tim, and I hope we'll have more discussion and more journal clubs as we have a deal before, because it's really interesting to hear from you. Because sometimes like we read about the statistics and actually most of them I didn't understand what they mean, but with you making the understanding is possible. Thank you, Tim. and thank you for the people who attended with us, and see you coming webinars. I have a surprise later on, so be stunned with Tariq's neonatology. We'll have a lot of people who will share their knowledge and their experience. Thank you, and I can say goodbye for everyone.
Thanks so much.
Thank you.
Bye, everyone.
Thank you. Bye bye.
Cheers.
Cheers.
Thank you.
Thank you.
Thank you. Bye bye.